dear colleagues, dear friends. It's my great pleasure to introduce the first interview in a series of interviews organized by the Committee on Ethics of the European Psychiatric Association. My name is Meryam Schouler-Ocak. I'm Professor of Intercultural Psychiatry at Charité, Universitätsmedizin Berlin, and I am the chair of the Committee on Ethics of the EPA. This series explores key ethical issues in contemporary psychiatry through conversation with leading experts, and it aims to foster interdisciplinary dialogue among clinicians, researchers, and, of course, other mental health professionals. By bringing together diverse perspectives, the interviews highlight ethical dimensions of practice, research, and policy, while encouraging reflecting and everyday professional work. Ultimately, the series seeks to contribute to an ongoing discourse on the ethical foundations of psychiatry and support ethically informed clinical and academic praxis. Today's interview focuses on a very important question for contemporary psychiatry. How should ethics be taught to early career psychiatrists and trainees? Our aim today is to reflect on how psychiatrists can be better prepared to address ethical questions in everyday clinical practice and how ethical thinking can be meaningfully integrated into psychiatric training. I'm very happy to introduce now our interviewers, our experts. I'm sure that you know both. Happy to see Professor Silvana Galderisi. Silvana Galderisi is Honorary Professor of Psychiatry at the University of Campania, Luigi, Vanvitelli. She is past President of the European Psychiatric Association, Chairperson of the WBA Standing Committee on Ethics and Review, and of the European Group for Research in Schizophrenia. Her influential research activity, she has been included by Clarivate in the worldwide classification of researchers, highly cited researchers, and focuses on psychotherapy, pathophysiology, treatment, and outcomes. And of course, Professor Silvana Galderisi is member of the Committee on Ethics of the European Psychiatric Association. I'm also very happy to introduce our next guest, Professor Luís Madeira. He is psychiatrist and psychotherapist with training in medicine, philosophy, and ethics. He is Associated Professor at the Faculty of Medicine of the University of Lisbon, where he directs the Center of Bioethics and Medical Humanities. And he also coordinates the Department of Psychiatry at Hospital CUF Descobertas. He is member of the Portuguese National Council of Ethics for the Life Sciences, and he serves on the EPA Committee on Ethics too, where he chairs also the EPA section on psychopathology. And he is currently president of the Portuguese Psychiatric Association. So let's start.
Thank you very much, Meryam, for your very kind introduction and also for organizing this important part of the activities within the European Psychiatric Association activities. I do believe that teaching ethics is an extremely important mission for all of us. It is a mission because I have to say, after many, many years of experience in an academic context, that when trainees in psychiatry come to us, they know nothing about ethics. There is nothing in, I believe, most medical universities that speaks to them of ethics. There is nothing, there are no formal courses concerning ethics in medicine. So they come to us that they don't know much about ethical issues in medicine and in particular in psychiatry, a discipline where ethical issues are even more important and relevant for our professional life. So for me, teaching ethics to young psychiatrists is something that is really extremely important. How do I think is important to organize these teaching activities? What is extremely important is to put them into the clinical context, which means making it clear that this is not something theoretical. This is something extremely relevant to everyday clinical practice. Most clinical cases do raise ethical issues. So what I do generally in my courses is that I teach the fundamental principles of both the World Psychiatric Association and European Psychiatric Association codes of ethics. And then for each fundamental principle, I have some clinical examples. What happens then is that after one or two clinical examples, trainees, early career psychiatrists provide comments, and generally they are quite happy to provide comments, or they themselves propose other clinical cases. And this is something that raises quite a lot of interest in the classroom, and also for them becomes, how can I say, something that they really learn. It's not only that they listen to, but they endorse the principles because they can see the relevance to the clinical practice.
Would you like to add? Professor
Thank you.
Vanvitelli?
Again, thank you very much for the kind introduction. Yes, so teaching ethics is a challenge. I've been teaching ethics for 22 years. And one of the things that Professor Silvana was just discussing is how can we transform theoretical knowledge into attitudinal experience for our residents. And that requires a lot. It requires first the introduction to the principles, to the theory. We cannot avoid introducing the theory. And then it requires that we present paradigmatic cases, but also that they bring their own cases. And also that teaching is longitudinal. So it's also important to see that residents do not just are taught in one moment of their residency, because later on they'll come up with other questions, other difficulties that they will face. So bringing one's own experience is one of the best ways to teach ethics.
Mm-hmm. And one question is also of interest. We have different parts in Europe and different legislations and, of course, theoretical frameworks and so on, also on ethics. What do you think about these issues? Can all these theoretical frameworks in different countries be included to the teaching processes?
So this is a very interesting question, because in the past, in the beginning, the teaching of ethics was dogmatic, which means that you said this is right and that is wrong. In the 90s, it became pluralistic. So these are the different possibilities you can do. And more recently, it has become declarative, which means that you have to justify your behaviors. You have to define it and justify it. So you have to come up with a decision on why you're doing this. And for that, we have to contextualize in your country what is possible, because my professor previous to me used to say that the ethics is the art of opening exceptions. So to open exceptions when you decide on something, you really should know what is the law and what is possible in your country. And so as a psychiatry, as a body of clinicians, we are regulated by a specific ethical codes that we now have for the EPA and for the WPA. But still we have to contextualize in the way we work, because we live in a country which is different. So it's very difficult to teach to everyone all the differences.
The next question is in this direction. When ethical principles conflict in practice, autonomy, beneficence, non-maleficence, justice, and of course confidentiality, how do you help trainees decide what carries the greatest moral weight in the specific case in these respective countries?
Well, I generally teach young psychiatrists that the fundamental principles should not be seen as a hierarchy, meaning that we should consider all of them on the same level of importance. For each individual case, then we need to articulate the principles and decide what should get the priority. Say that, I think that it is very important nowadays to make very, very clear that what is something overarching is the respect for the single individual person. This should be kept in mind and thought very, very well and clearly, that when a doctor has in front of himself, herself, a person, the first point is to respect the person's autonomy and dignity. Of course, this always needs to be reconciled as much as possible with the need for the best possible treatment in order to make sure that even when a person is not fully in charge of his insight, is not really able to make decisions, we need to support the person as much as possible in order to reach the position in which the person can be helped or again able to make decisions. Why this is extremely important? This is extremely important because we need to balance the two principles of autonomy and beneficence and also non-maleficence. So these three aspects need to go together, reminding always young people, young trainees, that the fact that a person is not able to make decision doesn't mean, or is not agreeing with other suggestions for treatments, for pathways of care, doesn't mean that we can abandon that person and tolerate that this person lives in a situation of neglect, poverty, and extremely poor outcome.
Thank you. Maybe we go on with the next question. We know that there are many, many aspects to be added, but the time is limited. So therefore, the next question of interest is capacity assessment, which is really central but often contested. Mm-hmm. And what are the main pitfalls clinicians may fall into, and what are the minimum elements of a defensible capacity evaluation in psychiatry?
Mm-hmm. Thank you. So capacity is a very complex decision process that it's mandatory that psychiatrists are able to do that. And one of the pitfalls of capacity assessment is to take the fallacy of an homogeneous clause. So this idea that capacity is for everything, and if someone doesn't have capacity, he cannot decide. So this idea that I can be unable to decide on my treatment, but I still can be capable of deciding if I want soup or if I want pasta. So capacity for different decisions is different. And also the fact that capacity is fluid, which means that it differentiates along time. So it's not something fixed, and it's not something homogeneous. And going again with Professor Silvana was saying, and she was mentioning the Convention of Rights of Persons with Disabilities, and this idea that since 2007, we have to be more than replacing patients in their decisions, we have to be helping them to make their own decisions. So this different position we now have is something that psychiatrists should be aware of to the extent possible in our severe mental illnesses.
Professor Galderisi, would you like to add something maybe regarding paternalistic attitudes of some colleagues?
Well, to this point, I have to say that there was a time when it was very difficult to convince students and early career psychiatrist trainees that the decision for treatments and pathways of care should not be only in the hands of the doctors and psychiatrists, of course, because they thought that since they become the experts of a discipline, they should be the ones who make the decisions. But I think that, luckily enough, we are beyond that. I can see in the new generation there is much more room for the idea of a shared decision making. Say that, we cannot say that we have completely solved the problem, because there are many, how can I say, there are many situations in which you can be trapped into the temptation of deciding on what another person should do at that moment of life.
Another question to you both. How do you address the ethics of involuntary treatment today, particularly when management pressures may call it with recovery-oriented and rights-based care? Mm-hmm. Very important topic now.
Yeah, it is. So involuntary treatment it has been for many years an important topic and key procedure that is part of psychiatric practice for many, many years. So the idea is that when you decide on involuntary treatment, you have to go against someone's own decision making. And that takes a toll in the psychiatrist. So it is very important that there are laws that support us. As in like in the 50s, when there was the definition of brain death. It was very important for people to turn off ventilators, because if you didn't have the concept of brain death, you were killing people. So this idea that we have to have concepts and laws to protect psychiatrists of their decisions so that they're able to practice and feel they are within their own practice. Saying that, involuntary treatment is always problematic, because you have to go and decide. And at that precise moment, you have to evaluate capacity. And since the CRPD, the Convention of Rights of Persons with Disabilities, a lot of mental health laws in Europe have been challenged to be reorganized, to become more able to protect patients. And to my understanding, involuntary treatment should not be focused on risk. So it's not the risk of this patient doing something bad to himself or to another, but it's the risk of being more sick due to the disease he has. So involuntary risk in treatment is the right of the patient to be treated. And as Professor Silvana was also discussing previously, this idea that autonomy cannot be a risk of social anomia, the risk that leaving patients to be by themselves. So, and lastly, just to add, one of the things for me it's very important, if any one of us has been severely sick, when we go to a doctor, we don't aim for full autonomy. We aim for a dialogical decision. So there are many moments where you just tell your doctor, you do as you think it's best. So it's not true that the outcome of all medical intervention is that the patient would decide alone. You have to be with the patient.
But what's about the management pressure or economic pressure?
Yes, there's we wrote a paper on the ethics committee on involuntary treatment, but one of the most important outcomes of that is that we need to understand that different socio-economical milieus determine the possibility of ambulatory quality of treatment. They determine the capacity to treat early phases of diseases. So definitely good services allow that we treat situations outside of the context of this context. But not all situations are ideal. So I just add to Professor Silvana.
I would like to add something, because I think this is an extremely important issue, also because it contributes to stigmatize the image of psychiatry and psychiatrists. So it's something that interferes also with the therapeutic relationships, with the quality of the therapeutic relationship. And there are 2 points I would like to add. The first one is that both involuntary treatments and other coercive measures have extremely different rates in different countries and contexts. This is something that it's still difficult to explain, because it is true that the the management pressure, the economical situations can contribute to that. But it has been demonstrated that this is not the only variable, because there is also the attitude of the leaders of the different services that influences quite a lot the rate of the involuntary treatments and of the coercive measures that are applied in psychiatry. So this makes extremely important teaching ethics in psychiatry, because when young doctors do understand the importance of respecting the persons, this is going to change their mentality in their profession. And when they become leaders, when they will be in charge of the direction of the services, they will have a different attitude, and they will learn how to change this attitude also in the other staff members, in the other people they work with, nurses, and all the other carers that are involved in the treatment pathways. The other point to be stressed is that whenever you avoid involuntary treatments and coercive measures, you save people from other traumatic experiences. We know that most of our patients have been exposed to trauma, to traumatic events. And sometimes this has been also a key factor in their disorder. So it's extremely important that we understand the need for avoiding other traumatic experiences. Experiences that are traumatic not only for the patients, but also for the staff members. So avoiding them as much as possible is something that is good for the whole practice in psychiatry. But as Luís was saying, it's not always possible. And we need to cope with that sometimes we really cannot avoid in order to protect ourselves, but mainly our patients.
So in this direction is the next question. What practical alternatives to coercion, involuntary treatments, and so on should be part of ethics training? For example, advanced directives or shared decision-making, de-escalation processes, crisis planning, and of course, community-based care.
Well, thank you. So you just named them a bit. So there are a lot of different ways to reduce involuntary treatment. And definitely involuntary treatment is different for different disorders. So in schizophrenia, in depression, in mania, the reasons to be admitted are different. And so what we have to address to avoid that outcome or that endpoint of treatment is very different for different disorders. We have many early interventions facing just the reduction of the solving of the crisis of the patient where he is right now. And for that, it's too extensive to just discuss here. But to my understanding, one of the most important trainings is also to allow staff to be trained in ethics in this respect. So this is very important. One of the things I notice in my hospital is that, for instance, nursing teams are rotative, so they rotate. As they rotate, they're always new, so they are never trained in psychiatry, and they are not even trained, of course, in ethics. So what happens is that if you have a team, other team members which are not trained, it's very easy to start a type of intervention with the patient that will have to become coercive at a point, because you need to really be very tactful. And that is a training that you need to address, and you need to train. And your teams need to have training on that respect.
That's very important. Thank you so much. Maybe one other question regarding involuntary treatment issues. In your view, where should the limits of coercion lie in psychiatric care? You mentioned it, maybe we can repeat it or underline it again.
Well, yes, I think that the limits is really concerning the border between the risk of damaging the person because you omit the care. We know that many people who are hospitalized involuntarily, maybe because they were suicidal at a certain point in life, then they come back to us, say thank you. They say thank you. They say thank you because now this is over. They feel better. they again have regained hope, and they can look at the future, and they can understand that that was just a very difficult moment in their life. The same for the psychotic episodes. We know that the duration of untreated psychosis can make a lot of damages in the life of a person. We know that it is really something that is influencing negatively many indices of outcome. So the fact that we leave a person with their psychosis without any kind of intervention is posing another very important ethical problem. So once again, we should balance the principle of autonomy with the principle of non-maleficence and keep that in mind always. But I agree very much with what Luís was saying before concerning the fact that even in these cases, when people reject treatment, the fact that you have a very well-trained staff means that this can be solved in a quite short time. You know, because if a person enters a place where the atmosphere is welcoming, is warm, they can gain trust towards the people around. This then makes the dialogue much more powerful. And so the possibility to come to an agreement on the pathway of care is much more feasible. But this requires people who are trained, as you were saying. So rotating nurses are really a nightmare, in my opinion. I will never go for that.
I'll just add something on coercion, just underlying what Professor Silvana just told. It is this idea that contemporary ethical models see coercion not just from the outside, but also from the inside. And in psychiatry, many diseases are coercive forces to do things. So sometimes an external intervention, though it looks coercive, it's just repairing the coercion the person experienced. And we have a lot of studies on anorexia nervosa where people are coerced by inner forces to continue, and they need external interventions to correct it. If we see only the external force, it looks like it's coercive, but indeed it's protecting. So it's very, very important to know that there is also internal forms of coercion.
So, do you think that the topic of digital tools entering psychiatric practice, from telepsychiatry to apps, passive data and artificial intelligence supported decisions, should be part of teaching ethics to trainees in psychiatry, early career psychiatrists?
Thank you very much. I think this is an extremely important topic too. And I must admit that I have not yet introduced it in my teaching ethics in psychiatry. And I think that we all need to teach early career psychiatrists, trainees on this topic because it is becoming extremely important in our everyday practice. There has been an explosion of especially with the COVID time, we had an explosion of telepsychiatry. That means a contact between the therapist and the people with lived experience, maybe on the phone, maybe online, via Zoom and the other means of communication. But also, there has been an explosion of the apps. And this is probably more concerning as an issue than telepsychiatry itself. The reason for that is because while in the first issue, the first topic, telepsychiatry, that means communicating not in person, but via digital mean, as implications for the privacy, for the consent to treatment, and for consent to the encounter and so forth. In the other case, the world of the apps, the topic is much more worrisome. The reason for that is because these apps are most of the times developed without any kind of in-depth competence, respect of the rules, and I have learned that there have been already cases in the United States where the harmful potential of these developments has been fully experienced, which means there have been apps that have meant for people to be exposed to harmful behaviors suggested by some kind of artificial intelligence they could access online. There have been cases in which even apps approved by the FDA turned out to be not as reliable as they should be. So the need for gaining experience in this world and defining the rules around this world is extremely important. And one of the reasons why I have not yet introduced in my teaching this topic is because I think that we have not really coded them very well in our ethical codes. So it's something that needs to be developed also in terms of code of ethics of our association, World Psychiatric Association, European Psychiatric Association, and of course at the national level, where some rules need to exist, but still is a world which is developing very fast, so probably we cannot postpone the issue any longer. So what we can do at the moment is teaching early career psychiatrists about the risks for the therapeutic relationships, the risk for the people to be left alone in this uncontrolled world without any specific guide, but also about the risk that in a context in which resources, both human and financial, are not enough, the temptation of replacing real care, good care, with an improvised digital world is quite high.
I add one question and then you can answer. What would you highlight as the most important ethical red lines in this issue?
Yeah, so I think Professor Silvana already told us. So we as psychiatrists are facing the impact of the digitalization of care. First of all, we have patients who have become ever more visible. So there's a new concept today which is called extimity, which is the opposite of intimity, is the drive to expose your intimacy online. And that has afflicted our patients, has transformed the way that some symptoms appear to us. So training is also important, the way we can assess patients' new symptoms. We have a new category called snapshot dysphoria, in which you want to make your body look like the filters you use in the apps you use online. But then I have the other layer, which is our own practice, in which we use either digital tools which were present since COVID or even AI more recently. And we now, for instance, I could speak about this for a very, very long time, but we now have the AI scribes. A lot of people use AI scribes to do the minutes of meetings. And it's now being introduced also into our own clinical appointments, even in my hospital. They want to have an AI to listen to the appointment and in the end summarize the appointment. And it's, for me, problematic because the nature of medical judgment is a narrative. And when you're being taped, what happens between you and another person is very different because you know you're taped. So it transforms your experience, the experience of the other, and even the summary. It's not because we psychiatrists and other medical professions, when we organize our clinical journal, we organize a narrative which is contextualized. It's not just a list of things that were discussed in that context. But most of medical journals throughout the world are being transformed right now into just lists made by AI scribes. And this is definitely an ethical issue. Not to say, and lastly, the idea of the protection of data, which is the last thing, which is very obvious. Like, this is sensible clinical data, and many AI platforms are open sandboxes. So they are usually accessible, they can be pirated. And so this is another issue, and just stressing how important it is and how urgent it is, the discussion on this topic.
Do you have some take-home messages or take-away messages?
Well, the first message, I think, it's never run your training in psychiatry without including ethics. It's extremely important that all trainees are exposed to a formal training on ethics in psychiatry. I agree with Luís that longitudinal is much better than one shot. I mean, just a course in 1 year is not enough, but either during all the professional encounters or as formal courses every year is very important that trainees are exposed to an ethical training, because then they can frame all the problems they encounter in their professional life in terms of ethical issues. And they can rely upon principles that have been established across time and across many discussions, the experience of many people who have been studying these topics, and they can benefit from all that experience. So this is the first take-home message. The other important message is, of course, to keep updated. Updated because it's also unethical to provide people with treatments that are outdated, that are not really evidence-based. So this is another important aspect that is an ethical aspect, but it's also a professional aspect. That's the other important take-home message. And I leave with Luís the task of completing
Thank
the
you.
take-home messages.
Thank you very much. So I think this was mostly well presented exactly how it is, but I would add just that training on ethics is not just good for practice, and this is a very important take-home message, because if you're not trained on ethics, your behaviors in psychiatry can cause you compassion fatigue, because all the situations that we have to face as psychiatrists take a toll on your experience. And as a doctor, you'll see 10, 20 patients a day. And in the end of the day, you are challenged. And if you're not trained, you cannot feel comfortable with the decisions you made. You'll have to make involuntary admissions, and that will also take a toll. So all this training also prepares yourself to deal with it and to be able to be comfortable with decisions you make and navigate situations of ambiguity, of uncertainty, never forgetting that all training in medicine is positivistic. It shows that everything seems to be obvious. Diagnosis seems to be like very technical, and in contemporary practice we have a lot of situations in which we use magnetic resonance. Everything seems very objective, but in the end of the day, most of our clinical practice is very difficult because we have to make many decisions in an uncertainty situation. And ethical training is very important for that.
Thank you very much. This is really very important what you have underlined as take-home message. The next aspect is resources and further readings for our audience. What would you like to recommend?
Just saying that medical ethics has a lot of books. And one of the most important books on medical ethics writes that psychiatric ethics is the medical ethics ugly duckling, because it's very, very hard to teach and very hard to understand. So one of the, as an ethics professor, I would say is take home at least a basic manual of medical ethics. There are many medical ethics. I will not advise for a specific medical ethics, but definitely find supervision. So most of the resources correspond to the capacity of having someone who is trained in that to discuss the cases with you. Because transforming theoretical knowledge into applied capacity and attitudes requires dialogical interventions.
I fully agree. I think that it's important for people to read books, articles, but what is very important is also guarantee trainees, early career psychiatrists, that some mentors are there and they can rely upon their experience and their knowledge to feel more comfortable with their profession, with their training, and never feel left alone with difficult decisions.
Thank you so much for your inputs and for your insight experiences which you shared with us, with our audience. We have to come to the And to conclude, we would like to note that this interview proposed by the Committee on Ethics of the European Psychiatric Association will be made available at the EPA platform of learning platform, and all of you members of the EPA have access to this interview. We hope that this discussion will contribute to ongoing reflection on ethical questions in psychiatry and support training and education, particularly for early career psychiatrists and trainees. More broadly, our aim is to encourage continued dialogue on how ethical thinking can be integrated into psychiatric training and everyday clinical practice. We hope that this conversation has sparked your interest, and we look forward to welcoming you again for future interviews organized by the European Psychiatric Association's Committee on Ethics. Thank you very much for your attention.